Hello, my name is Dr. Jim Quinn. I'm a professor of emergency medicine at Stanford University, and I'm pleased to present today an artificial intelligence machine learning algorithm that we have developed at Ceribell to diagnose seizures in real time and its implication in emergency medicine. I'd like to also recognize my other co-authors who are instrumental in developing this system and doing this study. I'd like to disclose that I serve as a scientific advisor for Ceribell, and that although I am a professor at Stanford University, my position at the university has nothing to do with the work in this study. Non-convulsive seizures and status epilepticus is a real cause of unexplained encephalopathy in the emergency department. One study found that seizures were present in 13% of patients with unexplained altered mental status, and about half of these were in status epilepticus. The lack of timely EEG diagnosis in these patients can result in severe brain injury. The Rapid Response EEG system is a portable EEG recorder and disposable electrode headband that has been developed to address delays in diagnosis. It provides a bedside EEG that can be reviewed in three ways. One, the waveforms on the monitor. Two, the EEG waves themselves can be sonified for easy bedside discrimination by providers. Three, by a remote review by the EEG waveforms by remote neurologists. And four, we describe a novel AI and machine learning algorithm that can evaluate the burden of seizures and determine seizures in real time at the bedside. This algorithm has been recently cleared by the FDA based on this data I'm going to present today. Briefly, the Aai algorithm reviews EEG waveforms in 10-second increments and reports seizure burden based on rolling 5-minute interpretations that are updated every 10 seconds. It then provides a reading of seizure burden. For example, a 90% seizure burden would mean that for the last 4.5 minutes out of 5, a patient was having seizure activity, and this would come close to the diagnosis of status epilepticus. For example, this patient here has 96% seizure burden, which would mean the patient would be in status epilepticus and need treatment. To validate the algorithm, 353 EEGs were reviewed by expert neurologists. These EEGs were from 6 different hospitals, academic and community centers, and included emergency department patients as well as ICU patients. The experts classified the waveforms by consensus into seizures, highly epileptiform patterns, and normal slowing. The algorithm performance was then compared versus neurological classification. Here are the results, and they're quite impressive. For determining status epilepticus, the algorithm was 100% sensitive and 93% specific in detecting status epilepticus. And also of importance, of the 179 EEGs where the algorithm said the seizure burden was 0, only 2 of these were identified by the experts to have any seizure activity, and all these lasted less than 30 seconds. This reflects a 99% negative predictive value for ruling out seizures, a very important factor in the emergency department. Also of note, if you look at the algorithm, its performance against the consensus findings versus the individual experts versus the consensus is quite impressive. It actually performs better than any of the experts in predicting seizure activity. In summary, we would describe an AI algorithm performs better than expert neurologists and was recently cleared by the FDA for the bedside determination of seizures in real time. And while the study did not assess the impact on patient care, it has several possible impacts on clinical practice. One, for the immediate diagnosis of non-convulsive status epilepticus to shorten the time to diagnosis and treatment. And 2, to safely rule out non-convulsive status epilepticus cases as well as seizures. This will reduce the unnecessary and over-treatment of these patients.